Hi everyone, I'm Mark from ASAP Cardiac, and today we're going to take a look at the Adult Synergy Arrest Protocol High Performance Team Response and the rationale for why it's different than the standard 6-person response we've all learned. First, a couple of changes. We got rid of a couple of positions. The first one we got rid of was the team leader. Why did we get rid of this? Well, where did it come from? Before we were doing pre-hospital arrests, we had in-hospital arrests. And when someone arrests in the hospital, everybody would rush there. The doctor walked in and he would start assigning roles. He was in charge of what's going on with this patient. He had to figure out why they're arresting and start assigning roles. From that, they developed the 6-person team algorithm that we've all learned forever. The reason we got rid of that is we don't need someone going, why are they arresting? We know why they're arresting. The science is very clear on this, and it's on the website. The majority of these arrests are due to arrhythmias, sudden arrhythmias. Number one cause, almost 90%. The next common cause is respiratory in nature, and the Adult Synergy Arrest Protocol addresses both of those insults very quickly. So we don't need a team leader. What we need is a choreography and a response. That's what we need, execution. Now, each of the positions in the high performance team response is compartmentalized. So there's not a lot of communication back and forth. Now, you're probably saying to yourself, well, who's in charge? Okay, who's running the code and who's in charge of the patient are very often two different things. I'll give you two examples. I was on a code team in a hospital, and I responded and I helped this doctor get through a 3rd-degree heart block, and he was very happy, and off we went. Not a week later, I'm doing chest compressions on arrest in the hospital. The doctor walks in, sees me, goes, and leaves. I'm like, yo, dude, get back in here, okay? Yeah, I'll run the code, but you're responsible for the patient. You're the doctor. Okay, example number one. Example number two, if I have a student going through their capstone events, they must run a cardiac arrest all by themselves. They have to run the whole thing. That's part of the graduation process. He's not responsible for the patient. It will always be the senior medic in the back of the rig. So who's actually running the code and who's responsible for the patient can be two different people. And we got rid of the team leader for that. The second position we got rid of was the person who's doing the documentation. If you look on the website, there's strong studies that prefer audio-visual recording, which is in our protocol, versus the old trying to remember what happened, writing it down, or looking at cues on a monitor. There's great discrepancies between the two, so we got rid of them. One, it's accurate. We know exactly what happened and when it happened to this patient. Two, as an instructor, that is invaluable material. That's your system CE right there, is reviewing those cardiac arrests because you have it on film. Everybody can see what they do. Sometimes you don't realize what you're doing until you see it on film, and film don't lie. The third position we got rid of was the drug administration person, because we don't need them either. We've de-emphasized epinephrine dramatically. It's not even in our protocols, but we still need vascular access, which is allowed in one of the team members I'll talk about in a minute. And if we need fluids, if we need antiarrhythmics, epinephrine we're not using because of its very strong association with poor neurological outcomes. This is discussed more on the website, but today we're just going through the response. So we have 4 primary responders. 5 and 6 can be runners, they have other stuff, but the 4 primary positions. Position number 1 will always be to the right side of the patient. This is a dynamic role, which means position number 1 can leave the patient. Yeah, they can leave the patient. They have the option to leave the patient. Position number 1 is concerned with chest compressions. That's their big role, is to always make sure that chest compressions are never stopped more than 7 seconds on this patient. They may have other roles, but their primary role is to watch those chest compressions and make sure they are always being performed. Now then, after we've put on the mechanical device, that position frees up. If it's a paramedic, they can get vascular access. If it's an EMT, they can do other things like getting information from the family, what happened, and running equipment, whatever else they need to do. So that's position number 1. Position number 2 is at the head of the patient, and this is a static position. This position never leaves the patient. It's responsible for placing the airway, in this case an eye gel. We're not bagging the patient. First breath of air goes through a supraglottic airway. We all know why. We're just going to fill up the belly. So the first breath of air through an eye gel, they're going to attach a rescue pod, an impedance threshold device, so we can optimize chest compressions and perfuse the patient. Third thing they're going to adapt is the end-tidal CO2 monitor, and we're using that to see how the patient's doing and to help guide our defibrillation. So that position never leaves the patient. It can be changed. That is to say, an EMT, say a paramedic put it in and we need the paramedic to start a line, that position can be handed off to an EMT. And most EMTs know how to put in, it's in their curriculum, to place an iGel, so that position can either be a medic or an EMT. But that position never leaves the patient. Next, position number 3, this is going to be on the left side of the patient, and this is a static role. This role will never leave the patient. It must be performed by a paramedic or higher. Primary roles here: 1, they're going to place the original standard ECG pads on the patient, get a quick look at that monitor. During deployment of the Lucas device, when the patient is up, they're going to place anterior and posterior pads so we can change vector and we have some different defibrillation options. They're going to be responsible for looking at the ECG, the end-tidal. They're also going to put on cerebral monitoring, and they are responsible for looking at that information, interpreting it. If the patient needs to be defibrillated, they call it back off. There's no discussion. They just do it. Position number 4 is a dynamic role. Their responsibility for placing and deploying the Lucas device, because we want them on a machine CPR as quickly as possible. Human CPR is just not comparable. We know that. The studies are on the website. So those are the 4 standard roles. If the Lucas device is put on by a paramedic, they can also, because it's dynamic, they can start vascular access, administer medications, perform other duties that a paramedic can. If it's an EMT, they can be a runner. 5 and 6 are just extra people if they happen to show up. But 4 is the primary, that's the best response we can have. Now again, these positions are compartmentalized, which means when we respond with this 4-person team, that person is carrying whatever equipment they need to respond to that call. This is a choreography, so we're not dragging everything in from the ambulance like we used to do. They only carry what they need for the initial management of this patient. So position number 1 is going to have a feedback device. Okay, they're starting compressions. Position number 2, and this equipment is either carried in a bag or in a vest, which I really like, is just numbered 1, 2, 3, 4 with all the equipment. Vest number 2 is going to have an ambu bag. It's going to have the iGel, the rescue pod, the end-tidal, so that they can place all those devices. Position number 3 will come in with the defibrillator, and if they have cerebral oxygenation monitoring, they'll bring that in too, but they're responsible for that equipment. Position number 4, they got the Lucas device. So all of this equipment, and just this equipment, should be coming in quickly. In addition to 1 and position 4, the vests also carry an IV setup and antiarrhythmic. So they're going to carry in, each of them has a 500cc bag, a catheter setup, tubing. So all this is on their person. There's no running around. What we have here is execution and choreography. This is what saves lives. The American Heart Association knows this saves lives. Hopefully when the new protocols come out, they'll be using this. But in the meanwhile, the only thing required to keep these survival rates low is for good, conscientious, honest practitioners to do nothing. So here at ASAP, we're doing something. And we're answering with the Adult Synergy Arrest Protocol and the High Performance Team Training. This is the best science for out-of-hospital adult cardiac resuscitation. I'm Mark. Thanks for watching. More on the website.